Hi, Dr. Wasserman. Thanks so much. Hi, Dr. We'll get started here. We have a lot to say because of our passion for each of our fields, so we'll kind of get right into it. We're going to talk about how we think about the management of prostate cancer, different considerations from each of our respective fields, and how we discuss treatment and manage some of the expectations for outcomes. So we will investigate how we pursue risk stratification for low, intermediate, and high-risk prostate cancer, understand the techniques for treatment, some of them, and that we look at outcomes not only based on oncologic control, that is cancer control and cancer cure, but also the quality of life outcomes that we want to maintain for our patients, namely erectile function, continence, and bowel function. And we'll also look at some of the features of high-risk disease and how multimodal therapy actually may play the best role. Prostate cancer is the most common non-skin malignancy in men. As you see below, the second death in this country. One question is, should we even treat prostate cancer? The prevailing narrative is that it's an indolent disease. However, there is randomized that the Scandinavian Prostate Cancer Group 4, also the PIVOT trial, which was done in the VA centers in the US, and the PROTECT trial out of the UK. So looking at each of these, so the SPCG4 randomized 100 with average issue about not only had an improvement in survival, we see that there's improvements in reduced evidence of metastasis as well. And this persisted regardless of patient age. There were initial reports showing that the benefit may only be in younger patients, 65, but as the data matured, and there's been about 18 plus median years of follow-up, we see that regardless of patient age, there's a benefit in terms of reduced metastasis, and bone mets can cause pathologic fracture and pain. From the PIVOT study, we see highlighted here that there was a survival benefit in terms of improved prostate cancer-specific survival for men. Trend for high-risk disease. And then we see from the UK PROTECT trial, randomizing a little more than 1,500 men to either active surveillance, radical prostatectomy, or radiation. When they looked at prostate cancer-specific mortality, overall mortality, and metastasis, they found that there was a higher rate of metastatic disease in patients who were watched by active surveillance versus those who were treated. In this study, they showed that there was it was necessary to treat 27 patients to prevent one case of METs. Subsequent per protocol analysis, meaning including patients who declined randomization but still got treatment, they showed that there was not only a metastasis-free survival, but also that those patients placed on active surveillance actually had worse prostate cancer mortality. So this is underlying, again, that treatment for prostate cancer, especially for the intermediate high-risk disease, is indicated and can save lives. So what do you do? So active surveillance can be used for low-risk patients. There is a percentage of patients that were progressed. We watched them closely with serial PSA, and in this day and age, MRIs and also repeat biopsies. Early local therapy for intermediate high-risk patients can afford highest chance of cure. Sometimes for high-risk patients, multimodal therapy is necessary, and systemic therapy, as you all know, for prostate cancer for localized disease doesn't consist of chemotherapy, but relies on androgen deprivation. So where do we go from here? So several things we take into account deciding how to treat patients. No patient is the same. We use a risk-stratified approach. One thing to keep in mind is that patients with less than 10 years predicted life expectancy are unlikely to benefit from treatment. We have no crystal ball to figure out how long patients are going to live, and I often tell patients we don't want to be morbid and focus on the end of things, but we want to be practical and say, okay, does this disease have a chance of reducing not only your quantity of life, but your quality of life? So a couple of metrics we can use are the Social Security life expectancy calculator. You can add 50% to this for good health and detract 50% for poor health. We can also use Carlson Comorbidity Index that can predict mortality. And these are metrics, again, to guide whether or not treatment makes sense given the patient's other comorbidities. Certain patient factors we take into account, such as BPH and the degree of bother from their lower urinary tract symptoms using the AUA symptom score. This might influence exacerbation of these symptoms with pursuing radiation, for example, and may underlie the rationale to pursue surgery to not only mitigate their urinary symptoms, but treat their cancer. Certainly, patients with a history of inflammatory bowel disease or history of radiation previously may not be candidates for radiation therapy, and also patients with prior surgeries, such as a TURP, might impact treatment decisions as well. We look at their sexual function via standardized and validated metrics, such as the Sexual Inventory of Health. We also look at patients' family planning. Part of a prostatectomy includes a vasectomy, so they can't inseminate normally, so it might impact their treatment decisions, especially for men who are younger, diagnosed or who have hereditary forms of the disease. We look at candidacy for surgery, performance status, and other things like obesity, COPD. The positioning for robotic surgery might be influenced by this. And also, it's hard to discount anecdotal experience. Because of the disease prevalence, about 1 in 7 or 8 Caucasian men, about 1 in 5 or 6 African American men will be affected. Most people have either a friend or family member who have gone through this. And it's hard, even though sometimes it's an N of 1, if this family member or friend has had a negative experience from a particular modality of treatment, it's hard to sort of convince patients otherwise. So that plays a pretty legitimate role in their decision making, and we can serve as resources to guide them and use our experience to set expectations. So not only do we take patient factors into account, also risk category, which we'll talk about, and we can use certain nomograms to determine the likelihood of cure based on a single treatment. Surgery alone is not enough, and patients who have a positive margin or locally advanced disease may be steered toward having additional radiation called adjuvant radiation. There are several side effects associated with treatment. Active surveillance actually can be associated with obstructive or irritative symptoms as the prostate enlarges as they age. Certainly these irritative voiding symptoms can also characterize side effects from radiation. Incontinence is usually a temporary side effect of surgery, but can be permanent in rare cases. And we also pay a lot of attention to bowel dysfunction, erectile function. Prostate cancer, I think, is probably a psychological disease as much as it is a medical disease, insofar as the sort of existential crisis that men face with the prospect of being permanently incontinent or having permanent erectile dysfunction. Often men, as they age, have differing degrees of this, and it sort of pushes up consideration of what it means for their identity to be faced with this at an earlier stage in their life. So we talk about that just as much, and again, setting expectations and doing the best we can. I often say that our top priority is cancer control, but we want to maintain as good functional outcomes as we can, and definitely take patient preference into account as well as our own experience. So how to stratify patients? We used the NCCN guidelines, National Comprehensive Cancer Network, using PSA grade by Gleason score to stratify patients into essentially 3 different categories: low, intermediate, and high. And as I mentioned, high-risk patients may require multimodal treatment. So there are several treatment options for prostate cancer, which adds to some of the sort of disorientation and confusion. There's a lot of resources online that patients pursue, and they can kind of go down a rabbit hole without understanding that their particular profile may not apply to certain treatment options. In the medical literature, it's really important to understand what risk category of patients are being included in particular studies when you're looking at outcomes and how those studies for especially new technology can be applied to our patients. So there's active surveillance for low risk. There's the sort of 2 gold standards, I would say: surgery and radiation. Radiation consists of intensively modulated radiotherapy or stereotactic body radiotherapy, which is kind of marketing-wise known as CyberKnife. It's offered at Georgetown. We also offer SBRT. Dr. Rao will get into this more as well. Androgen deprivation, we'll spend just a couple seconds to say that it may be used in combination with radiation therapy for intermediate and high-risk disease, and it's the gold standard approach based on level 1 evidence from clinical trials. So sometimes radiation is given as a combination therapy. Watchful waiting may be pursued for men who are diagnosed who have limited life expectancy. And again, these men may not necessarily even be screened because it's recommended men statistically less than 10 years life expectancy should not really even be screened with a PSA blood test. Some other treatments include cryotherapy, basically using needle ablation via freezing to do an invasive procedure under anesthesia to freeze the prostate. High-intensity focused ultrasound is a procedure used prevalently in Europe and is making its way over to this country, although it is not covered by insurance currently. And then there's promise, although not outside the setting of clinical trials, using focal ablation, either via HIFU or cryotherapy or microwave therapy or radio frequency ablation to destroy just a portion of the prostate rather than the whole thing. Conventionally, the treatment of prostate cancer has involved treatment of the whole gland because the entire gland tends to be involved. Even on a biopsy, when disease is found on one side, typically about 70+% of the time, there will actually be bilateral disease found at the time of prostatectomy. So sort of a whole as the standard of care. So some basic treatment principles: organ-confined disease is curable. Organ-confined disease is curable. From the PROTECT trial, we see that the 10-year cancer-specific survival rate is over 99%. Again, PROTECT randomized patients to active surveillance, surgery, or radiation. And the gold standard treatments are surgery or radiation. Multimodality therapy may be required. So I'll talk about surgery. So we, in the urology community, look at surgery as the gold standard treatment approach for men who are able to undergo the stress of an operation, and anesthesia clearance-wise, in terms of exercise tolerance and METs, would be the ability to walk up 2 flights of stairs without any adverse outcomes such as shortness of breath or chest pain. Early surgical morbidity was their volume there, please. We're getting a lot of feedback. Thank you. Early surgical morbidity with open prostatectomy was high, especially given rates of high stress urinary incontinence, erectile dysfunction, thorough understanding and evolution of the neuroanatomy and the sphincter complex, namely the external rhabdosphincter, modernized the approach to radical retropubic prostatectomy as pioneered by Dr. Walsh from Johns Hopkins in the early 1980s. And then further advancements in robotics and minimally invasive surgery have reduced perioperative and perioperative morbidity and improved long-term functional outcomes as well. The first robotic prostatectomy was reported out of Germany in 2001, and there's a graphic there of the original console that the surgeon sits at, as well as the early robot. And then the modern contemporary Da Vinci approach that was invented by Dr. at the Vaticular Urology Institute in Detroit, Henry Ford in Detroit, came on the scene in the early 2000s. So I actually trained, so my mentor, Dr. Badani, trained under Dr. Menon. So I would say that I'm sort of third generation in terms of robotic surgery training. So again, we look at radical prostatectomy, the gold standard therapy for surgical candidates. One of the advantages is that it allows more definitive staging and grading of the nature of the tumor beyond the biopsy. There's a chance for undersampling based on the fact that we can't put a needle into every millimeter of the prostate. So there's probably about a 25% or so upgrading or even upstaging. Some of the nomograms that we use that we didn't really get into can predict the rate of having extraprostatic extension or seminal vesicle invasion, which is locally advanced disease, which does happen. So it also allows us to sample the lymph nodes, which are removed during the course of the operation, so we can get an assessment of the stage grade and further stratify patients who may benefit from additional therapy, such as radiation or even androgen deprivation. So it gives us the best sense of what's going on. After surgery, to remove the prostate, the PSA becomes undetectable. It should go down to 0. So treatment failure, meaning a rising PSA at some point after surgery, is a reliable biomarker for cancer recurrence. In fact, historically, PSA was sort of invented as that purpose and has been reappropriated to be used in screening. And because of its lack of specificity, it has come under controversy, as many of you know. After surgery, as I mentioned, salvage or even adjuvant external beam radiation is still an option. It may be recommended for patients who have locally advanced disease or a positive margin. The converse, we say classically, is not true. Based on centers that do salvage prostatectomy, there can be fibrosis and sort of scar deposition that makes successful surgery after radiation a little more difficult. There's statistically a higher complication rate, a higher rate of injury to the rectum, and actually incontinence rates that are upwards in the range of about 60%. So although surgery is an option, we often steer patients away from that. So some of it is more of a marketing gimmick from the surgical perspective to say you sort of burn a bridge by doing radiation first. And certainly we're reasonable, for which patients we think would be good candidates versus patients that would benefit most from radiation. And we'll get into how we decide that in part of our multidisciplinary clinic. But that is something that we bring up, that is difficult to do surgery after radiation. Also, some candidates for radiation, as I mentioned, who have unfavorable intermediate or high-risk disease are best treated with concomitant neoadjuvant androgen deprivation. Several physiologic ramifications to that in terms of reducing quality of life with hot flashes, weight gain, loss of muscle mass, loss of libido, erectile dysfunction, dyslipidemia, bone demineralization things. Certainly the longer you're on the androgen deprivation, the more likely you are to have those side effects. But it's possible that for patients with unfavorable intermediate or high-risk disease, if they pursue surgery, they may not have to have ADT. Whereas if they have radiation, then ADT would definitely be indicated and beneficial from a prostate cancer standpoint. I tell patients that we're not trying to torture them, but at the same time we want to our top priority is cancer control. So surgery, you see in the graphic here, it basically is surgical removal of the prostate as well as the seminal vesicles and the pelvic lymph nodes. The cartoon on the left shows the anatomy of the prostate existing between the urethra and the bladder. After surgical removal, the bladder is anastomosed to the urethra, basically sewn, and then we do our best to preserve the cavernous nerves to allow for postoperative sexual function recovery. It's 85% of cases in this day and age are done robotically, which has been proven to have less blood loss, less pain, faster convalescence, and shorter hospital stay. There's also level 1 evidence demonstrating this. Our risks, as with any operation, we say heart attack, stroke, blood clot in the leg, blood clot in the lungs, pneumonia, bleeding, infection, risk of blood transfusion, neuropraxia or nerve damage from how we position patients for surgery. These are inherent to any operation. And again, we look at exercise tolerance to make sure patients are adequately cleared to move forward. Sexual dysfunction rates, namely the ability of patients to get erections, have a wide prevalence reported, and this is much a reflection of the surgery as it is patient performance going into the operation. The older the patient is, and in the literature, basically greater than age 65, as well as poorer sexual function going into surgery that we can quantify using that sexual health inventory for men metric, tend to do worse in terms of recovery. Younger patients who have good sexual function coming in often have good recovery. And again, it depends also on how much of the nerve we can spare and where the cancer is located in the prostate. Advances in MRI technology allow us to more definitively localize where the tumors are and to preoperatively detect extraprostatic extension. So it might not be safe to save the entire neurovascular bundle in the setting of fear of locally advanced disease. The expectation for continence should be that continence is restored. Pelvic floor muscle physical therapy preoperatively have been shown to accelerate recovery of continence, and the rate of permanent incontinence should only be about 5 to 10%. Sometimes it takes a year or so to restore continence. Men with larger prostates or with more urinary symptoms going into surgery may have worse recovery. There's also risk of positive margin with prostatectomy that might necessitate multimodal treatment. This is also based on Gleason score, and we use preoperative multiparametric MRI in this day and age to provide a reliable blueprint of whether or not attempting nerve sparing, which can increase the risk of positive margins, is advisable. So a couple of surgical things that have been shown to actually improve return of continence are preservation of the bladder neck or the internal sphincter, the internal smooth muscle sphincter. We don't want to leave disease behind attached to the base of the prostate, such as the base of the prostate is invading into the bladder. So you see here the cartoon up top that shows that this internal sphincter preservation can probably accelerate return of continence, may not have ultimately a better continence after a year, for example, but I think patients that we treat in this manner anecdotally have been well served. There's also reapproximation of the denomviates fascia with the rectourethralis muscle and the posterior aspect of the sphincteric complex. So this is a cartoon of a couple of the robotic instruments reapproximating this denomviates fascia, which separates the prostate from the rectum in general, with the new bladder neck that we've made here with the urethra here. So this provides posterior support and assists with kind of like a backboard that allows for coaptation or compression of the urethra during increases in intra-abdominal pressure. If this backboard is not here or is lax, then if there's an increase in intra-abdominal pressure, the entire urethra will descend and the patient will leak. So this has been shown to have an earlier recovery of continence. And then most recently, there's interest in doing a Rechius approach, which means that we don't violate the anterior anatomy, including the puboprostatic ligaments, but come through the posterior approach to remove the prostate this way. And there is, mostly this has been done without these other surgical techniques. So although this Rechius sparing technique is promising and has been shown with level 1 evidence, actually a recent randomized trial accepted to European urology from the folks over at Georgetown showed earlier recovery of continence. This is in the absence of these other techniques. So at this point, I would say the current state is, the Rechius sparing approach may be beneficial, but these other surgical modifications to the technique also afford benefit. So what do we do for erectile dysfunction? Basically, the ability of patients to have an orgasm is maintained. Again, as I said, because we do a vasectomy as a part of the operation, they have what's called a dry ejaculation. So anyone who's still considering having children has to be counseled. We have certain approaches to penile rehabilitation with using oral or phosphodiesterase 5 inhibitors in a daily manner. Also, the option of using a vacuum erection device or even doing intracavernosal injection therapy, which probably has the most potent impact on recovery and acceleration of recovery. I tell patients, this may sound horrible, especially as they're deciding what to do, but we have certain tricks up our sleeve in terms of getting them back to where they want to be in terms of their sexual function. A lot of the series that we'll look at in terms of reporting, including the JAMA article that Dr. Wasserman mentioned, it's sort of unknown, what the precise surgical technique was, and also what the rehabilitation strategy was for these patients, both in terms of pelvic floor physical therapy and even sexual function recovery. So, some of the findings that we'll discuss later may be taken with a little bit of grain of salt. The other thing too, the reports for sexual dysfunction, every surgeon is not the same. Dr. Tawari, who I trained with at Mount Sinai, did a lot of work on really understanding the neuroanatomy of the neurovascular bundle. With robotic surgery, we have a magnified visualization field, so we can actually see different fascial layers that I have a hard time believing that open surgeons could ever appreciate. And as you see, the experience of Dr. Menon, who pioneered robotic surgery for prostatectomy in general, his sexual function recovery rates, and this is 12 months. He published a paper recently looking at anterior versus posterior approach, are almost upwards of 80% at a year. Sometimes it takes about a year to recover sexual function. Sometimes it can be 2 years or so. But I would argue that in experienced hands, surgeon experience is very much a vital component to someone's recovery. So we're going to change gears here a little bit and have Dr. Rao talk to you about radiation.
All right. Thank you, everybody. This is James Rao. We're going to switch gears a little bit and talk about the alternative to surgery for prostate cancer, which is radiation therapy. And radiation therapy is done using a machine called a linear accelerator. We have 2 of these at GW, and this is a picture of one of them, which is located in the DC level of the MFA building. Modern radiation for prostate cancer uses something called intensity modulated radiation. We still treat the entire prostate, but we, in 3D, map out the prostate and adjacent structures such as the rectum, the bladder, the penile bulb, the femoral heads, and we use a complex optimization algorithm where beams from each direction are modulated so that a greater dose goes to the prostate and a lesser dose goes to the adjacent organs at risk. And the summation of all these beams results in a very conformal dose distribution to the prostate with avoidance of adjacent structures. And this is called intensity modulated radiation. Unlike with surgery, where the entire prostate is removed, the prostate is intact with radiation. So the question has long been, what is the appropriate radiation dose to give to the prostate? The radiation dose is defined in grays, which is a physical dose. It's just a joule per kilogram of tissue. And back in the day, in the 1970s, they really weren't able to go to a very high radiation dose. The dose is shown in this graph at the bottom with the percent of disease-free survival on the y-axis to the left. And as radiation technology became more advanced with 3D conformal techniques and then intensity modulated radiation and other techniques, we've been safely able to escalate the dose first from 60 gray, then to 70 gray, and more recently a standard of care that's closer to 80 gray. And there's been a improvement in disease-free survival associated with radiation therapy with each of these treatment dose increases. The most recent trial that has demonstrated this is a multi-institutional RTOG 0126 study that was published several years ago, randomizing patients to a 70 gray dose level versus a 79.2 gray dose level. And this is given in 44 treatments over 8 to 9 weeks. And although overall survival was similar, dose escalation did improve several secondary outcome measures. And this includes biochemical failure-free survival, which is defined as increases in PSA 2 above the nadir value. There was also a benefit in local failure within the prostate, as well as in reducing the rate of distant metastases and the need for secondary therapy. Unfortunately, there was a cost in increased toxicity with the higher dose level, but they also showed that IMRT had a benefit in that it had a lower rate of late toxicity compared to older radiation techniques. And this study really established 79.2 gray in 44 treatments over 8 to 9 weeks with IMRT as a standard regimen for prostate cancer treated in the conventional fashion. This is another study from MD Anderson that had even longer follow-up. The previous study only had about 7 or 8 years of median follow-up, and this one had a 15-year median follow-up. And they showed not only a difference in biochemical control, but also cancer-specific mortality. And this is the first randomized trial that has been published that has shown this difference with dose escalation and radiation treatment. Nowadays, with modern radiation planning approaches, we can do many different things to decrease the side effects of radiation to the rectum in addition to using IMRT. One of these things is a rectal hydrogel, which is a polyethylene glycol gel that's injected in the space between the rectum as well as the prostate under ultrasound guidance, as you see in the figures above and the figure to the left below. And this moves the rectum away from the prostate, typically by about 5 to 10 millimeters, and allows us to provide improved dose distributions for radiation treatment and decrease rectal toxicity. And then this hydrogel is naturally absorbed by the body over several months. This is a randomized trial that demonstrates what I just said. In the top graph, which demonstrated the bowel quality of life reported by the patient, there is an improvement by placing the hydrogel in the bowel quality of life. And then in the bottom two graphs shows the incidence of rectal toxicity, both grade 1+ versus grade 2+. And as you can see in the dark line, which is the control without the hydrogel, there is some incidence of rectal toxicity, and that's what we would expect with radiation treatment. But the rate of grade 2+ rectal toxicity is basically zero, even in the long term, in patients with space OAR. And this is a significant improvement over what was done before. And nowadays, we are trying to place space OAR hydrogel in most of our patients who are treated with prostate cancer to reduce this rectal toxicity. There are other things that can be done from a radiation perspective to reduce toxicity. One topic that's been of much interest over recent years is proton and particle therapy. These are heavy particles that it can be used for radiation treatment rather than photons, but it does require larger and more expensive equipment such as a cyclotron. And this is a typical facility as you see below, with the cyclotron to the top left and then the gantry in the treatment room to the right. And it's hard to see, but the patient is actually that very small dark line that's in the middle of the gantry on the right-hand side. And as you can see here, this requires a construction of an entirely new building just for proton therapy. And this results in a very expensive construction and maintenance costs. The hypothetical benefit of proton therapy is shown here. And this is due to something called a Bragg peak. In the top line that's dark, you can see the dose distribution of the X-ray as it goes in the body. And that's with photon therapy. There's a buildup that reaches a peak, and then there's a gradual drop-off. Proton beams don't behave in this manner. So at the bottom line, you can see a monoenergetic proton beam. And what it does is it goes to a certain depth, which is from the left to the right, and then drops off most of its energy at the Bragg peak, which is the sharp spike in the green line. You can use a beam spoiler, which spreads out the Bragg peak so that the dose is deposited at the depth of the tissue, and very little radiation dose is deposited deep to the point of the tumor. And it has many hypothetical benefits in dose distribution. Here's an example of two plans, a proton beam plan to the left and an IMRT beam plan to the right. As you can see, both of them adequately cover the prostate, but the proton beam plan distributes radiation dose at a low level to the tissues around the prostate much better than the IMRT plan does. So although there is this benefit in where the dose actually goes, there has been some difficulty in proving that clinically this has any significance. This is an example of a study published in JAMA. It's a database study using the SEER Medicare database. And it is a propensity match comparison of patients treated with proton and IMRT up to that time. And interestingly enough, it showed no benefit to proton therapy in disease-free survival compared to IMRT, which is what we expect because we go to the same dose with proton therapy. But proton therapy was actually increased with more rather than less GI toxicity in this study compared to IMRT. Right now, there is an ongoing randomized trial randomizing men between proton beam therapy and IMRT to the same dose with bowel quality of life as well as toxicity as outcomes. And hopefully that will give us conclusive data on whether there's any benefit to proton beam therapy versus IMRT in prostate cancer. So this is very important for figuring this out. The other question that's interesting over the years is whether we can do radiation treatment in a faster way and whether this will result in a better outcome for patients with prostate cancer. And this is a concept known as hypofractionation, and taken to its extreme, it's called stereotactic radiation. So first of all, why do we give conventional treatment in 8 to 9 weeks? It's because we give a small dose over that time, and most cancers are quickly growing to normal tissues, and fractionation increases the therapeutic ratio. However, prostate cancer is also slowly growing, and on the basis of modeling studies, it was thought that perhaps speeding up the radiation therapy would at least lead to similar cancer control and potentially even better cancer control while maintaining an equal amount of toxicity. And data supporting this assertion has come out quite recently. This is a study published in JCO that tested a 5.5-week course of radiation treatment, which is shown in yellow, versus a more standard treatment in about 8 weeks, shown in blue. And as you can see, for biochemical failure as well as disease-free survival, at least in patients with low-risk prostate cancer, the outcomes are exactly the same. Now let's talk about the extreme of SBRT, which is a very shortened course of treatment, typically over 5 radiation treatments. This is commonly called CyberKnife. However, CyberKnife is a brand machine, as you see to the left, but there are other machines that can do essentially a very similar treatment. And we use the TrueBeam with rapid arc technology that is also capable of SBRT treatment. And what we do in that instance is we compress the treatments even further into 5 treatments, which is thought to be quite similar to these other forms of radiation treatment in terms of cancer control. The cost is that there is a little bit more acute toxicity. And also, since SBRT treatment is relatively new for prostate cancer, there is a lack of long-term outcome data. So we're still awaiting 10 and further outcome data for these treatment modalities. Another treatment modality for prostate cancer with radiation is prostate brachytherapy, which is the implantation of radiation seeds in the prostate. And that's the way it was traditionally done. However, as brachytherapy technology has advanced, we actually use a different method of treatment now known as high-dose rate brachytherapy. And it is my opinion that HDR brachytherapy will eventually overtake LDR for most prostate applications in the future. The benefit of HDR brachytherapy is that there's no radiation exposure to staph, and there's potentially lower toxicity as you're able to better tailor your radiation dose. And you can see the HDR brachytherapy machine to the bottom left, as well as a radiation source, which is a small iridium pellet welded to the tip of a wire and the dose distribution around that wire. And after catheters are placed inside the prostate under transrectal ultrasound guidance, this is what it looks like in the OR, and this is a cartoon showing the needles. A cystoscope is placed to make sure that they do not penetrate into the bladder. The patient undergoes radiation planning, and a radiation plan is generated. And ultimately, these catheters are connected to the machine, which has a radiation plan programmed into them for the radiation treatment delivery. Afterwards, the catheter is removed and the patient can be discharged at home. All of these radiation approaches have the goal of covering the entire prostate to the prescription dose. However, the dose distribution within the prostate is somewhat different between brachytherapy to the left, IMRT in the middle, and SBRT to the right. Most prostate cancer occurs around the periphery of the prostate in the peripheral zone, and HDR brachytherapy, at least hypothetically, is able to maximize dose in those areas. IMRT results in a relatively homogeneous dose throughout the prostate, and SBRT actually has the maximum dose in the middle of the prostate near the urethra, and therefore SBRT potentially has the consequence of greater urinary irritation, at least in the short term. The takeaway from all of these things is that almost all modern radiation approaches, including IMRT, SBRT, protons, and brachytherapy, are very low late toxicity and are also very effective for prostate cancer. And to demonstrate that, there's a review article that has the toxicity for urinary toxicity and GI toxicity to the left and right respectively, with all these different treatment modalities. SBRT are the bars to the far left, external beam is in the middle, and 3D conformal has higher toxicity, but the ones to the middle and to the right are IMRT, which are quite low, and then brachytherapy is all the way to the right. And you can see that all of them are really quite comparable. And if you look at it closely, one may even argue that proton therapy seems to have a little bit more toxicity compared to the other approaches. So in general, all of these are reasonable for localized prostate cancer, and the choice is usually based off of patient preferences and convenience rather than the tumor factors themselves. So when I counsel somebody with low and intermediate risk prostate cancer, this is a typical discussion that I go through. I say that radiation and surgery are likely to be somewhat similarly efficacious, and both are good choices for treatment. Active surveillance is also an option for the appropriate patient, but there is a risk of metastasis with surveillance that could have been prevented with treatment. Surgery and radiation ultimately have effects on sexual function, and they're probably similar, but radiation effects can be delayed for months or years in the future. Surgery is more likely to potentially have some urinary toxicity, including risk of incontinence, but radiation is more likely to have rectal and bowel toxicity, including bleeding, although this can be decreased with the hydrogel, as we talked about before. Radiation side effects will accumulate over time and appear over years and decades, and there are secondary cancers that are a possibility, but are rare. And for the reasons above, I tend to direct younger and healthier patients towards surgery, but older and less healthy patients towards radiation. But most patients can have either treatment depending on their preferences. And in regards to radiation itself, the current state-of-the-art standard of care is IMRT over 8 to 9 weeks with markers and hydrogel. but this can be shortened to 5.5 weeks in many individuals, or even 5 treatments for the appropriate patient, with the caveat that short-term side effects may be greater and long-term outcomes are still not available. Brachytherapy is also safe, effective, and convenient, and although proton therapy has theoretical advantages, we're still waiting to see if it's proven to be safer and more efficacious in clinical trials. And with that, I'll turn the lecture over.
Thanks, Dr. Rao. This is Michael Whalen again. So we'll basically, we presented surgery, we presented radiation. We'll talk about, what the evidence is in the medical literature to guide us. There's limited level 1 evidence. The PROTECT trial out of the UK did randomize patients. Historically, there was thought there was an aversion to randomization. So level 1 evidence really doesn't exist. And even contemporary studies such as PROTECT have not been primarily powered to look at the differential oncologic efficacy of surgery versus radiation. The other thing is that some of the evidence we have in the literature in a retrospective way has used antiquated technology. I mean, technology improves, open surgery became robotic surgery, external beam radiation at lower doses became IMRT or even SBRT at higher doses. And because prostate cancer is so slow growing, you need 10 plus years of follow-up to really demonstrate the differences in cancer-specific survival. So because of that long follow-up time needed to show efficacy, the treatments change over time. So you're often reflecting kind of on a bygone era. There may be selection bias, such that patients who have surgery are younger and maybe are better surgical candidates than those who are offered radiation, who may be older because they can't undergo the stress of an operation. And also efficacy is looked at by multiple domains. So not only cancer outcomes, but also functional outcomes, looking at side effects. And it's very hard also to look at late toxicity. A lot of the follow-up in some of the studies that we have, even if it's 10 years, patients will live more than 10 years. And as Dr. Rao mentioned, although rare, late toxicity from radiation can be very difficult to treat, and often is, I would sort of say, has not been captured well in the medical literature. So looking back in time, we have some evidence through meta-analysis published in 2016 that used prospective trials and tried to control for various confounding factors, namely age, by only including studies that reported multivariable adjusted hazard ratios. So it included almost 120,000 patients looking at all modalities of radiation as well as surgery, and we're looking at overall mortality and prostate cancer specific mortality. They also looked at sort of the old era versus the new era. And there was their findings in this meta-analysis showed that there was an improvement in overall survival seen above and prostate cancer specific survival seen below on the forest plots for surgery compared to radiation. Substratifying this, they found that for each risk category, low, intermediate, and high, there was a differential advantage for surgery, as well as the studies that had longer term follow-up. And those studies that had more than 8 years, there's about a 2-fold improvement in prostate cancer specific survival for patients who had surgery. Again, attempting to confound, for age. The other thing is that patients who have radiation may be higher risk, and therefore, anticipated higher rate of needing adjuvant radiation after surgery, so maybe counseled to have radiation up front. So this meta-analysis, breaking it down by risk categories, attempting to control for that as well. However, we didn't know what the neoadjuvant adjuvant deprivation therapy practice patterns were in these studies. It's possible that these studies using radiation were underdosed because the recommendation for using higher doses was published in 2019. This was older, and also the rates of postoperative salvage radiation may play a role here. So getting into the functional outcomes, that was sort of a plug for surgery in terms of oncologic outcomes. Functional outcomes have been looked at in multiple studies, including the prostate cancer outcome study, PROTECT, and then most recently the JAMA article that kind of was the genesis for this talk to begin with. So we'll spend some time talking about that. So it was a series of almost 1,500 men looked at from 5 different SEER centers, as well as a U.S. Cancer Registry, diagnosed from 2011 to 2012. About 30% were high risk. They each underwent sort of the standard treatments for prostate cancer, and then they mailed surveys to the patients at 6 months, 1, 3, and 5 years. The surveys were the EPIC scores, which looks at urinary irritative symptoms, incontinence, sexual function, bowel function, and hormonal function, as well as the SF-36, which looks at physical well-being, emotional well-being. This is sort of a more modern experience. In PROTECT, the majority of patients were open radical prostatectomies. In this current series, about 75% of them were robotic surgery. And again, it was modern techniques for radiation. The median age for the radical prostatectomy group was younger than the radiation group. Also, they had better baseline sexual function. The radiation active surveillance groups had worse energy fatigue scores and worse general health. And then over time, urinary incontinence was consistently worse for radical prostatectomy. At 5 years, about 10% versus for radical prostatectomy versus 7% for active surveillance. However, at 5 years, there was no difference in report of it being a big or a big problem according to patients. Also, erections sufficient for penetration were reportedly worse for radical prostatectomy versus active surveillance. And similarly, more men reporting it as a big problem in radical prostatectomy. However, if you looked at men who had sufficient erections for penetration at baseline prior to treatment, the outcomes among different treatment modalities were similar. It was certainly less than active surveillance, but among radiation versus surgery, it seemed to be the same, which kind of dovetails with what Dr. Rao was saying. Over time, sexual function declines for radiation. Most differences were attenuated at 5 years, although incontinence was worse for radical prostatectomy. Unfavorable risk disease had worse erectile function at 5 years with surgery as well. However, some limitations to the study is that it's not clear what the pelvic floor physical therapy regimens were, what the different surgical techniques used. Did they use the Rocco stitch or bladder neck sparing, which tend to be more modern. Also, the extent of nerve sparing for the favorable intermediate and unfavorable intermediate treatment groups was not specified. The penile rehabilitation strategies were also not made clear. A lot of the rehab strategies using phosphodiesterase inhibitors in a daily or PRN way came after the 2011 and 2012 from the era from which these patients were recruited. So it's likely that patients have actually better function given our modern penile rehab strategies. And also duration of androgen deprivation sort of wasn't clear here. So one thing to point out briefly is treatment regret, which can be a big problem and really necessitates patient counseling. So many series have investigated this, reporting regret in about 15 to 30% of patients. Some cited reasons are incomplete information from the treating provider, some of the urinary symptom effects, as well as sexual dysfunction. You'll see that histogram there says among stratified patients in blue, looking at the left, 31% 31% say that they received complete information regarding the cancer compared to 14% of men who had regret. And similarly, among satisfied patients, 40% said that they had complete information regarding the consequences on the urinary system compared to 17%. Overall, I would say that these numbers are pretty low and really points to informed consent and counseling. This may be limited by recall bias. I mean, there's a 5 and 15-year post-treatment survey. Men may have sort of overestimated their function preoperatively and sort of overestimate their dysfunction postoperatively. Ways to mitigate this regret is, again, through counseling and informed consent, also setting expectations for patients. And one thing we do at GW is using a multidisciplinary approach where Dr. Lin, Dr. Rao, and myself will spend time talking to patients and setting their expectations and finding out what their values are as we proceed with a treatment plan that's personalized for them and their function and their comorbidities. It's important to identify and validate these side effects, to not minimize urinary incontinence, to understand how it's having an impact, and to stratify these patients for salvage treatments such as artificial urinary sphincter or a mesh sling placement, which are surgical things that can, through surgical techniques that can help restore continence, and even using various penile rehabilitation techniques or sort of the standard surgical treatment of erectile dysfunction in this setting, which would be to insert an inflatable penile prosthesis. So we'll skip that and then go on to Dr. Lin for medical oncology.
This is Jianqing Lin. Thank you both for a very comprehensive review of localized prostate cancer. For the sake of time, I think I probably will try to leave some time for questions and answers. And I think for medical oncologists, actually, we stand beside with our urologist and radiation oncology colleagues because this is truly a localized disease. The main treatment are local intervention. But I think what American Society of Clinical Oncology also has in publications endorsed AUA and ASTRO and SUO about this, how to manage this disease, because there is still lots of controversies and challenges in this specific disease. We certainly would help in terms of manage this local disease in terms of decision making, and try to educate and help manage a patient to determine the benefit and the risks. Is very, very important to prevent treatment to degrade, as Dr. Whalen mentioned. So I think Dr. Whalen already mentioned about our multidisciplinary clinic. I'm a true believer about this approach. Many cancer centers adopt this approach, and this is very, very useful. In a GW Cancer Center, we offer patients that once every 2 weeks to once a week, every Friday afternoon, we have subspecialty physicians and with help of patient navigators. And in the future, I hope that the radiology and pathology and also genetic counselors can be involved as well to improve our quality of a multi-D clinic. For medical oncology, I think our focus is actually for high-risk disease, localized disease. You can see from the CO database that about 12% of patients presented with a regional disease, which means this patient may have lymph nodes involvement already, T3 or T4 disease already, and this patient likely belongs to NCCN category of high risk and very high risk patient. And this patient likely needs early systemic treatment in addition to definitive local therapy. And what this slide shows that in addition to definitive surgery or radiation therapy, which are the key treatment component for this localized disease, I think what we want to achieve is that can we improve long-term oncology outcome? As you know, for high-risk disease, for Gleason score 8 to 10 disease, 15 years prostate cancer specific mortality is very high. It's around 30% average-wise. I think if we can do neoadjuvant androgen deprivation therapy plus docetaxel chemotherapy, certainly this trial, randomized phase 3 trial, has been completed, and no final result is yet. But this is what we want to achieve to reduce the prostate cancer specific mortality. And the other approach is that can we use a novel hormonal agent such as abiraterone acetate to completely block androgen receptor function, and we can achieve a pathologic complete response, and then potentially we can achieve long-term disease control. And as Dr. Whalen already mentioned, the neoadjuvant, concurrent, and adjuvant androgen deprivation therapy in combination with radiation therapy is a current standard of care for high-risk disease. And lots of study has been done and been done already for adjuvant approach for patient who has received surgery or after received radiation therapy. I'm not going to have time to go to this point. So I think at this point, I think what to make a quick conclusion is that standard kind of treatment is for localized disease, active surveillance, radical prostatectomy, and radiation therapy is the main treatment option for localized disease. Multimodality therapy, as I mentioned, is very, very key for high risk and very high risk disease to achieve a final oncology outcome. Certainly, it may cause more side effects, certainly, because we give more treatment. And now, results from neoadjuvant chemotherapy randomized phase 3 trial is completed. We certainly are waiting for the result. adjuvant docetaxel chemotherapy after radiation, this RTOG 0521 has completed. And we know that 6 cycles of docetaxel chemotherapy adjuvantly give for patient after radiation therapy improve disease-free survival and overall survival. And this is the current standard of care. We should be able to discuss with the patient for this option. And we don't have time to discuss about the genomic studies, certainly including germline genetic testing in this high risk and very high risk patient population. Certainly this is updated in NCCN guideline already. And I think I'll stop here to hopefully have some time for questions. Thank you.
Guys, that was amazing. You did it. You did it in an hour. It's exactly what I would hope for, to give us all the options that we can talk to our patients about. I think the most important thing is you've developed a lot of great treatments, and it really is a discussion with the patient and his physicians to decide what's best for them. Let me ask you one thing. I can't pick up a New York Times Sunday magazine section without reading about high-intensity focused ultrasound. Could somebody just talk about that for a second?
Yeah, so HIFU, like I said, so it's been used in Europe for many years. It has a C code for use here, but it's not covered by insurance. I mean, there are centers that are doing it. It's especially interesting for focal therapy. HIFU is a technology basically causes prostate ablation. And the FDA approval in this country is for prostate ablation. It's not for prostate cancer treatment. So you can basically ablate the entire prostate. You can do hemiablation or you can do focal ablation. So actually, I can go back and I can look at this because I skipped over this in the effort of time, but I have this exact thing where we use MRI now to find the lesion, right? In a way that the prostate's walnut size, it's small. Tumors within the prostate are sub-centimeters, so hard to find. But MRI technology, we now use 3 Tesla magnets, can find them. High-intensity focused ultrasound is a planned treatment where you, similarly to radiation, kind of put in a program. You use a transrectal ultrasound probe and then do the planning, and then it creates these kind of rice grain sized ablation zones that overlap, and it takes a while to do under general anesthesia. However, there are limitations. In a recent study showed actually that with great methodology, meaning they did focal ablation. They even did like an 8 millimeter treatment margin, so to make sure that they got a normal margin around the tumor, and then they did Doppler flow of the ultrasound to make sure there was no blood flow, meaning they ablated the zone that they intended to ablate and there was no viable tissue. And then they did a saturation biopsy of the prostate at 6 months, and about 40% of them had residual significant prostate cancer, meaning high-grade cells. So, a subtotal treatment, and the ability of the MRI in this setting to detect it was only 14%, and only about 70% actually had preserved sexual function. So, continence was great, but in terms of this being the holy grail, it's definitely not that. And the reason for that is because the MRI probably underestimates the tumor extent, meaning, there's been whole mount studies where, the MRI slices the patient in a particular virtual way, and then we can orient the prostate in that same way and slice it. It's actually, difficult to do this, but is done. And then you see how they kind of slice it up, and it mimics the MRI virtual slices. And you find that the extent of the tumor on the pathology when the prostate's removed actually goes much more than we anticipate based on the MRI by about 1.3 centimeters. So, it's not established what an appropriate treatment margin is. And then obviously, as you ablate more, you have less of the neurovascular bundle involved. So it's promising, it's being studied, it is offered. We don't know also if, you burn this and then try to have surgery, if the neurovascular bundle will be stuck here and you end up having a worse surgery outcome than if you had just done a bilateral nerve sparing surgery to begin with. So it's of interest. Sometimes, the idea of beating back the cancer just enough to, live out your years is a consideration as well. But it's not ready for prime time, in my opinion.
So Dr. Simons was asking, are we using patient decision aids to help patients decide what to do in clinic?
We don't have standard metrics. It's part of the informed counseling. There's actually an ongoing project now that we're looking at trying to get a pilot grant to kind of study this in a better way. Mandy is involved in basically spearheading this, and it's been looked at. I think assessing what's important to the patient, especially for those who may still be family planning or want children, assessing sexual function, again, understanding that that's what I mentioned where the psychological part of it is. It's unfortunate that they're dealt with this particular condition because regardless of the treatment, especially in the setting of needing androgen deprivation with radiation, each of the sexual function outcomes is sort of the same, or can be equally as poor over time. So, setting that expectation is important. We don't have standard questionnaires that we give patients to understand that. It's more of it more comes out in the discussion.
Yeah.
But I think it's an active area of study, and it would be interesting to see how that might make render more explicit what's important to them. Because these decision aids are meant to do that, to highlight for the patients who may not have had to think about this before, as they're sort of paralyzed and numb from the diagnosis of cancer, to get out from them what they find important. I mean, we attempt to do that, and that's where I think giving patient information for the Prostate Cancer Foundation, the Urology Care Foundation, we understand that they're only going to retain about 30 to 40% of what we fire at them during the course of the visit. It's important that they have these other resources and brochures, and then come back to us at a different time, I think, after we've had the multi-D. But if you're aware of some of these decision tools that we could easily incorporate into the clinical flow, I'd be more than happy to try them out and to incorporate them.
Right. Yeah, it shows how a multidisciplinary clinic, especially in this area, is just incredibly important, as is the role of the navigator, probably. Guys, thank you so much. This is terrific. This is exactly what I want. I really appreciate it. And everybody, we'll see you next week.
Thanks very much.
Thank you.
Oh.
You did.
All right. Thank you.
That was great.
Use positive stuff.